Hello, this is Dr. Mike, and this is our last chapter that we are going to deal with in our study of developmental psychology, and it is on death and bereavement, which I think is a good chapter for you if you're nursing. And of course, we always use these things in our personal lives. As a pastor for 20 years, I spent a great deal of my time in funeral homes and nursing homes and hospitals, more than I ever did in the pulpit, because we always had someone that was in the process of dying and going through bereavement. And you deal with it every day as a nurse. And so I know that it's going to be something that will be beneficial to you as we take this time to discuss some things that maybe you need to understand in this last process of the lifespan. And then there is a short wrap-up video that you will just take just a couple, 3 minutes long, where I talk about the benefits of the course again. And I hope you will follow through with that and find it to be helpful to you. So let me open our screen for slides, and let's talk about the idea of death and dying and bereavement, which are major pieces of the life that we live. That's the one thing for sure that we know as human beings, that we're going to die at some point, and you're going to deal with death. You're going to deal with death in your family. You'll deal with death in your patients, depending on what kind of job you have as a nurse. You may be dealing with it daily. So there's always something there to think about, to deal with that yourself. I don't know about you, but as a pastor, I would get other people through the process. And then about 2 or 3 weeks later, I'd be depressed about it. So I had to deal with it. And there's nothing wrong with that counseling. So by the end of this chapter, you ought to be able to summarize how we define death, what the ethical issues are that come from that, and how adults typically experience approaching death. We'll talk about ways in which people make and express decisions about their own death. And then, of course, the process itself, the types of grief and different patterns and experience and bereavement across the lifespan. One of the things of concern to me as a amateur psychologist would be the COVID pandemic recently, and the more than 1 million people that died from COVID without the benefit of going through the bereavement process. As a culture, we have certain things that we do. We gather with family, we gather with friends, we have a meal, we talk, and talk therapy is always the best therapy. If you get people to talk about a situation, it's always the most helpful thing that you can do for it. We missed all of that. We missed the ritual of having a funeral service, of going to the graveside, of saying our goodbyes. And for many people, because of COVID, they weren't even able to say goodbye to their loved ones. They never got to see them for the last time. And of course, had been separated probably for some time before that due to the contagious nature of the disease. And so it is really hard. And I think there's a lot of pent up guilt and maybe anger over that people haven't dealt with. And I think it will cause them a lot of psychological problems. I think maybe we're seeing some of that in the reaction that people are having, various things in our society. So who knows? So we'll talk first of all about how death is defined, and then what the medical criteria are used to determine that. What are the ethical dilemmas surrounding that, and what issues the cost of life, of sustaining life artificially, which is a big deal in the day that we live in. It can cost millions of dollars to keep someone alive by technology. Thanatology is the word that is not often used. That's the Latin word for, in Greek, in the study of death or dying or grief or bereavement, the social attitudes toward these issues. One of the things that's interesting is that in every culture, they treat death differently. And so it's very interesting when you live in a different culture to understand that death of that person or that group may be a little bit different. Death's a very difficult concept to define precisely. Amazingly enough, you'd think it'd be easy, but it's not. And different cultures have different meanings, as I've said, and the ways that they ritualize or they deal with it psychologically. Mourning rituals, expressions of grief, states of bereavement. Queen Victoria, when Albert died, never wore anything but black again. She wore her widow's rags, as it was called, up until the day that she died. She never really got over the grieving process. So from definitions, clinical death is basically the lack of a heartbeat or respiration, but there can be other activities that are still going on at a lower level that we don't notice immediately. Whole brain death is declared when the deceased meets 8 different criteria, which were established back in 1981. So that's much more the accepted way to do this now. It takes about 20 minutes to declare someone actually dead. 3 primary signs of permanent, irreversible loss of all function, brainstem reflexes not working, and breathing has stopped. Those are the major criterion. This is the definition used now in most countries, and somewhat different criteria for determining brain death are applied at different hospitals, but that's debatable. Brain death is also controversial from some religious perspectives. They would have a problem with that being the criteria. You can be in a persistent vegetative state, and that you will have an maybe even irreversible lack of cortical functioning, but continue to have brainstem activity. So that part of the brain can still be functioning, and the other factors not be functioning. So basically, different states, like the vegetative state, will allow for spontaneous heartbeat and respiration, but not consciousness. So consciousness is not one of the determiners here. The whole brain standard does not permit a declaration of death for someone who is in a persistent vegetative state. So they are kept alive artificially on machines. There's a lot of ethical issues, and you may have taken or will take my ethics course, maybe in some time in the future, but bioethics is a study of the interface between human values and technical advances in health and life. And it kind of grabbing a respect for individual freedom and the difficulty of establishing what is moral through common sense and rational argument. And that process tries to honor the importance of individual choice and weigh a treatment's relative benefit versus the harm to the patient. You can virtually keep people alive indefinitely. Well, I say indefinitely, that's limited still, even on a machine for weeks and months, actually. And so the question is that really living? Is there any hope of recovery? What kind of quality of life do they have? Those are all issues that doctors try to get families to see. But I know from having been a pastor for 20 years that the real issue is guilt. Most times when they're in that situation, they want to hold on to their mother or their father or their son because they really maybe failed them. Maybe they didn't visit them. Maybe they didn't care. Maybe they didn't show their love enough. And now they think by holding them here, they can somehow gain some kind of penance for that. It doesn't work that way. And so hospitals will give you a little bit of time, and some of that is just about money. I've been in many a situation where there was a surgery, say on Monday morning, patient had a problem, had a stroke or whatever, and they are clinically, on life support. And the doctor said, well, we'll wait and see. And by Wednesday, they're still waiting to see. Thursday morning, they dropped the bomb that, well, we're going to have to start thinking about, life support because there's no brainstem activity, there's no death. So Friday morning, they'll say, well, we need to take them off life support. So by lunch, they're gone. Now, the doctor probably knew the same thing on Monday that he knew on Friday. What's the difference? It's money. That's probably another $100,000, $200,000 a day to keep a loved one alive that's already gone. And it's not a good idea to do that, but families will do it invariably over guilt, over issues. If you want to see what your family's made of, wait till you go through a death in the family, and you'll see what kind of ethics and things that they have, because all this guilt comes out. Another issue we talk about in ethics is euthanasia, the practice of ending life for mercy's sake. That's what I was just discussing. Active euthanasia is deliberately ending a person's life that may be based on clear statement of that person's wishes. They have said they don't want to be on life support, and it should be a decision made by somebody else who has the legal authority to do so. Either that person has given them a power of attorney, a final say legally. You have to have that. You cannot go on somebody's word. Passive euthanasia is just to allow someone to die without giving treatment. If they're in bad enough shape, you just let them go. It poses the moral dilemma of deciding under what circumstances you're going to end a person's life, and that whether that person wants to be left alive by a machine, or whether they suffer terminal illness and they're in great pain, whatever that is. All those issues come up under euthanasia. There is physician-assisted suicide in some places, not widely. It was tried in the 1990s. A guy named Jack Kevorkian had a band that he put together that would come to your house and help you off yourself. He ended up getting sent to prison, dying in prison. But in some countries, it is legal. If there's no hope for improvement, no release available, patient is competent, patient makes a request repeatedly over time, then two physicians will review their case and agree. And that's only, that's in other countries. Oregon does have a Pass the Death with Dignity in 1994. It was the first physician-assisted suicide law in the country. It remains in place, even though the Supreme Court ruled that there is no right to assisted suicide. In 1997, Oregon still has it in place. The price of sustaining care is always an issue. Money is always an issue. There's an intense debate about that. Most of our medical resources are being eaten up and eaten away with this kind of thing, and yet you can't set up some board to determine who should live and who should not. But money, of course, like I said before, keeping someone on life support for a day is probably in the neighborhood of $100,000, depending on what they're being given, of course. And so it's really something to think about. So let's think about the personal aspects of death, first of all. We want to do, how do feelings about death change over adulthood? How do people deal with their own death, and what is anxiety, and how do people show it? Those are all things that I've dealt with quite a bit as a pastor, and things you see over and over again. The shift from formal, operational, and post-formal thinking kind of helps young people kind of integrate emotions and thought about death. It's very traumatic if you've ever been around a teenager going through the loss of one of their best friends, killed in a car accident, OD'd with drugs, whatever. They're at a very different stage in their development process than, say, older adults. Now, mother and parents is another thing you can imagine. I would say that I think the most gosh awful, horrible thing is to outlive your children. I have seen that happen so frequently, and just saw it with a dear friend of mine a few weeks ago, where his son was 49. I was killed in a car wreck, and I've never seen grief and anguish like those parents. Only son. They did have a daughter, but it was traumatic. Parents' death is kind of designed to help middle-aged people think about their own death, and older adults are generally less anxious about death. They accept it more. They realize it's coming. I listen to Jimmy Carter, who is almost 100, who is on hospice and has been for months. His wife just died. Listening to him talk about death is wonderful, because he has such a great perspective. When he got cancer, he did a TV interview about it, and it was really, really interesting, really encouraging. But this is where we talk about in the infancy. Remember, back at the beginning, we talk about the attachment theory, where the baby learns to, by being held or whatever, attaches itself to the mother, attaches itself to the father, and how important that is. And I think that's probably one of the best frameworks to understand how adults deal with death and how they grieve, is that attachment issue and becoming unattached. Dealing with your own death is a process. It varies based on disease. When you hear the word cancer, you have a pretty clear view of what awaits you. Others don't do that. And today, of course, we have not really cured cancer, but we have prolonged the lifespan. So more and more people are living with cancer. There's a psychologist study, the Kubler-Ross stages of dying study. That's kind of what we go by in dealing with it. There are 5 stages. There's denial. And in that denial, you first hear the news, you're in shock, you're in disbelief. Second is anger. You're you're hostile and you resent it. Why me? Why do all these good people have to suffer and all the bad people get by with, being bad? And then you bargain, looking for a way out. Some people bargain with God. If God will give them extra time, they'll change the way they live or whatever. I've heard all that. Then there's depression. You're not able to deny it, but they go through this issue of sorrow and loss and guilt and shame, and then finally get to acceptance of death is inevitable with peace and detachment. Not everybody goes through all 5 of those stages. Some of them get hung up. I have literally seen people dying that had to be held to the bed, screaming and that kind of stuff. But you not all of them, and in the process you go through, you don't go at the same rate, same time. So those are pretty important to think about. And this might be something you want to make a note about, because if you have to deal with a patient or whatever, realizing that they're whatever stage they're in might help you to be more comforting and more helpful. So from a contextual theory of dying, stage theories don't state what moves a person through the stages. There's no single correct way to die, of course, and people vary in how they approach these 4 tasks or issues for dying. One of them is bodily needs, psychological security, interpersonal attachment, spiritual energy, and hope. So a contextual approach provides guidance for healthcare professionals and families for discussing how to protect the quality of life, provide a better care, prepare caregivers for dealing with the end of life. So basically, it's a guide to help you to help you face it, because in many instances, especially those that work in nursing facilities, where the people are there every day for year in, year out sometimes, and they become a part of your unofficial family, whether you want them or not. They're still there. You talk to them every day, you deal with them every day, and suddenly when they're gone, there is a grief factor on your part that you have to deal with, and you see the anxiety. For some people, the fear of death is big, is of dying. Theory of management theory addresses why people engage in certain behaviors to kind of achieve these states. So read through these, and I'm not going to read them to you, but read through these and think about that. It's interesting. I think they do mention that men show more fear than women of the unknown. More women are afraid of the dying process, but more men are afraid of the death itself. So we've done neuroimaging as a way to provide a useful framework for studying brain activity as related to death, and it shows us a lot of really interesting things. So basically, I know people that don't want to think about dying or death, but I think it's healthy to think about it and to go through that process. So end of life issues, just briefly, what are they? How do you find a scenario? What's a palliative care issue? End of life are issues pertaining to management of the final phase of life. After death, the deposition of the body, the memorial service, the distribution of your assets, all those are part of the psychological process of letting go. Prior to the current generation of older adults, people rarely planned ahead for their wishes, making their wishes known about medical care they didn't want. And now this is much more common for people to have living wills and all these prenuptial agreements. But the final scenario is a way for people to make their choices known about how they do or do not want their lives to end. And one of the most difficult, important part of this final scenario is the process of separation from family and friends. That's usually the hardest. Palliative care is focused on providing relief from pain and other symptoms of disease at any point during the disease process. That many times the treatment they give you for pain, like morphine, will eventually lead to the person's death, but they look at it from the standpoint that the good outweighs the better. And so you keep someone alive when they're in excruciating pain, or do you give them something to help them, but that knowing that medicine is probably going to ease them on out the door. Hospice is one of the great organizations in the world. If you have a chance to work for them, I highly recommend you do that. They assist dying people by emphasizing pain management, palliative care, death with dignity. they're so good to the family and treat them so well. I have nothing to say but good to say for them with the loss of my mother, because they were so good to us. But they support all kind of things. You know, the events after death, even the funeral, and all kind of things. So hospice is very, very helpful. So be sure you read that through very carefully, and in case you ever use that for your family. So making intentions known is a big part of the psychology of this. A living will, as I said, healthcare power of attorney, you giving somebody in particular the right to make life and death decisions for you, or a DNR, do not resuscitate. And remember the DNR, this is something some people don't know. The DNR has to be with you to be of any value. It has to ride with you in the ambulance. It has to be at the hospital. They have to resuscitate you if they do not have that signed piece of paper by a judge. So keep that in mind. I personally live by myself. I don't have any friends here. So I keep my DNR pasted on the back door, the only door in and out of my house. So the ambulance drivers coming in have to have it in hand and take it to the hospital. But this is a very important piece of paper and a great way to, you know, be sure that you make the right decisions. So, so how do you get over the loss? How do you get over the grieving? How do you survive that? There's lots of things that you need to do about that. Grieving is a very real process. One regret that I have was, as a pastor 20 years, is that I did not encourage people to take the grief counseling funeral home offers more often, because I think it's helpful. All the sorrow, the hurt, anger, guilt, confusion, sometimes been building up for years. Oh, just comes, you know, descending at one time. It's called mourning. It's a part of the mourning process. And grief is a process that's variable. It takes extended amounts of time before you move on. So it's worth thinking about these kind of things as you read through this. There's a lot of different grief reactions. You know, anything in the gauntlet you can run, and people express those kinds of things. I've seen everything that you literally can imagine. I had a 42-year-old suicide once and had 2 teenage children. I've virtually lived with them until I got them restarted. I've had lots of people that weren't old people by any means, that died, and you had to deal with it. I've had people fighting over property at the funeral, those kind of things. And so you cope with it by looking at this 4-component model that's very helpful to you. And I want you to read that. I want you to think about that. Coping, emotional regulations, you know, and be sure you get rest and that kind of stuff. So read those models very carefully, and I think that they will help you. So if you do end up not having any kind of resolution, they have a word for that called ambiguous loss. Some people can be very present psychologically and be gone physiologically, to the point that people see them. They see images of them, which is a whole nother story. But just want you to know that's possible. Prolonged grief is very, very detrimental to health. So it does need to be dealt with. The depression, the suicide ideations need to be, don't take those for granted. If someone tells you that they're going to hurt themselves, get help immediately, especially as a caregiver, because you are responsible. So you need to help with that. So there's all kinds of different kinds of grief that a counselor will deal with, and it's very helpful for you to read through this very carefully. So experiences across the lifespan of death. Children have a particular understanding of death. We usually crouch that in some idea about heaven, so that they're able to think about it. Adolescents do again, and many of them have already rejected the ideas given to them as children, but so they go through it very different, especially if it's a parent, someone close to them, then it's very difficult. Preschoolers and adolescents look at death in certain ways. They experience the loss of a family member. Sometimes that can be very detrimental. It can be very depressing for especially an adolescent. person. In adulthood, one of the worst things you can do is lose your partner, and it takes a long time to get over that. But some people never get over it. So understand that as an adult, and I highly recommend you to go get the funeral home grief counseling, because it will help you get back into that. I think I mentioned this already. The saddest thing I can think of is for you to have to give up your child, and after you've born him or her. And I had a preacher friend who was having some digestive problems, went to the emergency room one day. He was 47 years old. And when they did the x-ray, he had esophageal cancer from acid reflux. And they sent him directly on to Duke University Hospital in Durham, North Carolina. By the time they got there and looked at it again, the cancer had already devoured so much of his throat, voice box, that whole area. They had him on hospice. This was Friday when he went there. By Tuesday, he was on hospice. He was dead by Thursday. So it's quite shocking to the family. But to lose a child is very, very traumatic. Losing a parent is probably the second most traumatic. It's really hard to lose a child because of the buffer between what they've done for you and what you are up to now. Late adulthood is a little bit easier. I don't think it's ever easy, and so you just don't ever take that approach. But I think it's a little simpler because they were getting ready to go. So they're lived out their lifespan. Many older people are discouraged. They're waiting for the next life to come. So, the idea of leaving is some people are just tired and ready to die. So you work through that, these things, look at the assessments, think about that as far as yourself's concerned, and think about what it means to die. I don't think it's anything to be afraid of. I have great confidence and great hope, and I'm hoping to live another 30 years, but if I don't, then it's all right. But read through this chapter. It's one of those chapters I think will help you and be of great value in the future. So we'll talk to you soon. I wish you the best of luck in your studies, and if I can ever be of help to you, please let me know. Thanks.